Good afternoon. I would like to thank Dr. Cusimano for the invitation to present today on pulmonary tumors that invade the hearts. This is my disclosure. Speaker fees from Bayer on that board meeting from Actelion on AstraZeneca. So tumor that invades the heart can be differentiated into predominantly lung cancer, which will be the group of T4 tumors, mediastinal tumors, and a separate group will be the pulmonary vascular tumor or the sarcoma or intimal sarcoma, which I will go in more details at the end of the presentation. So factors that affect survival in T4 non-small cell lung cancer includes predominantly complete R0 resection. Generally, these tumors have to be resected with a lobectomy or occasionally a pneumonectomy, but not lesser resections such as a wedge resection. We do need to have a mediastinal nodal status evaluated either by endobronchial ultrasound or mediastinoscopy to rule out mediastinal lymph node disease. And frequently, we will treat these tumors with induction therapy, either chemotherapy, chemoradiation therapy, and more recently, possibly immunotherapy or chemoimmunotherapy, which may improve the chance to achieve an R0 resection and optimize local control. These patients are assessed from a physiological standpoint with a pulmonary function test, VQ scan, particularly if pneumonectomy is anticipated, and echocardiogram. The clinical staging is performed with a CT scan, a PET scan, a brain MRI, and as I mentioned, mediastinal nodes are evaluated with EBUS or mediastinoscopy, and occasionally we will use a cardiac MRI as well. This assessment must be done before the induction therapy, and some specific tests are generally repeated after the induction therapy, and in particular the CT scan, and occasionally the PET scan or the MRI. Now, the T4 tumors that infiltrates structures outside of the chest can be differentiated into those that will involve the thoracic inlet, which is the larger group of patients, and these often are referred as Ponco's tumor. The second group of mediastinal tumor are also often classified as T4 tumor. And then carinal resection and SVC resection are another group of patients who require or can require a T4 resection. The overall survival generally for T4 tumors is around 35 to 40% at 5 years. And this is the series from the group in Paris who has one of the largest experience with T4 tumor. As you can see, 271 patients in that cohort. Now, the limitation when we looked at mediastinal tumor is often related to the trachea, and particularly at the level of the carina. Resection of tracheal and carinal component is limited to 3 to 4 centimeters. Particularly due to the aortic arch, which limits the ability to bring the left main bronchus into the trachea. And the aortic arch will often generate some tension if more than 3 to 4 centimeters of tracheal resection is performed. And you can see on this right lateral view after the pneumonectomy, the left main bronchus, the distal end of the trachea, the mediastinum, and the SVC that was partially resected. So the distance here generally should be less than 4 centimeters to limit the risk of tension on anastomotic problem. During this resection, we use a cross-field ventilation with a second ventilator system that is sterile, and then the anastomosis is done hand-to-hand between the trachea and the left main bronchus. Occasionally, this central mediastinal tumor, in addition to invading the carina, can invade the SVC on more rarely, but occasionally can invade the right upper pulmonary vein. And this is a patient from Paris that had the chance to operate with Dr. Dartavel, where you can see the resection of the SVC, the carina, on the upper pole of the left atrium that was resected with a stapler, and then the reconstruction between the SVC and the atrial appendage with a graft. Other type of tumor which may require SVC resection are mediastinal mass. This is a germ cell tumor that extended across the SVC and invaded the left and right innominate vein. And generally, if both innominate veins are needing to be resected, one of them can be reconstructed, as you can see on this intraoperative picture. Now, tumors that extend throughout the heart can also involve the aorta, and most frequently they will involve the upper part of the descending aorta close to the subclavian artery on the left side, as you can see on this picture. And these tumors may require resection with either partial bypass with VA ECMO, cardiopulmonary bypass, and less frequently, a gut shunt has been described between the ascending and the descending aorta, or you can do a clamp on resection. But generally, the best approach is to use a partial bypass, and nowadays the ECMO is certainly the optimal technique. With partial ECMO, which allows perfusion of the upper part of the body and perfusion through the ECMO of the distal part of the aorta. The approach in order to expose the subclavian artery can be through an anterior approach, extending from the neck into the third or fourth intercostal space. The neck extension can be along the clavicle, supraclavicular incision, or along the sternocleidomastoid muscle in order to have a more posterior exposure, particularly if the tumor extends towards the vertebral artery here. The trapdoor approach is again most commonly used, and involves an incision along the lower part of the neck above the clavicle, then a midline stentomy that extends in the fourth intercostal space, which gives us the trapdoor approach to expose the upper mediastinum on the left lung. If necessary, the first rib can be resected with a small counter incision in order to open the window between the clavicle and the first rib, particularly if the subclavian vein is involved. If the tumor extends along the subclavian artery, the area to look at is the lower extension of the tumor, whether it extends to the aortic arch or involves only the subclavian artery, and then whether the vertebral artery is involved, in which case the dissection will extend higher up in the neck through an incision along the sternocleidomastoid muscle, which will provide exposure to the upper part of the neck and the posterior part of the neck, which allows resection of the vertebral artery, exposure of the brachial plexus, potential resection of the T1 nerve root, the chest wall, and then the subclavian artery can be resected distally and proximally on the aortic arch with a stapler here, and then the subclavian artery can be reanastomosed into the carotid artery, and the tumor is resected en bloc with a lobectomy through the second intercostal space. Now, for tumors that are more extensive, extending to the dome of the aorta, the posterior part of the aortic arch, the resection is more complex and will require potentially cardiopulmonary bypass or partial ECMO, as I mentioned, in order to be able to dissect and reconstruct the distal part of the aortic arch. On the subclavian artery can also be reanastomosed into the carotid artery. This is a patient who had surgery conjointly with Dr. Oreopoulos several years ago, where the tumor was extending down along the subclavian artery to the dome of the aortic arch. And Dr. Oreopoulos did right to left carotid bypass. And then that patient was treated with an aortic stent in order to limit the need of cardiopulmonary bypass. On the stent was advanced close to the innominate artery. On the left carotid artery was covered and therefore required the right to left bypass for completeness of the resection. Another type of tumor that can extend toward the heart, which are not frequent, but certainly well manageable with cardiopulmonary bypass, are tumor that involves the left hilum and extend along the left pulmonary artery to the bifurcation with the main pulmonary artery, as you can see here. These tumors can be resected through sternotomy or trapdoor approach in order to expose the main pulmonary artery, go on cardiopulmonary bypass, resect the tumor, and then the main pulmonary artery can be reconstructed with a patch. And this is the patients at 3 months postoperatively. You can see that the phrenic nerve was involved, and there is an elevation of the left hemidiaphragm. Now, you can have a tumor that extends into the pulmonary artery lumen, and these are a lot less frequent, but an important group of patients to monitor and assess. This is a patient who eventually was diagnosed with a carcinoma, which was originating from his left lung and extended into the pulmonary artery, and he presented with pulmonary emboli, shortness of breath, and was found to have that intravascular extension of his disease. So that brings me to the third group of patients, which I will discuss in more details, which are the sarcoma of the pulmonary artery. These are patients who frequently present with progressive shortness of breath, occasionally chest pain, and very often will be misdiagnosed as an acute PE. Generally, the suspicion of sarcoma or malignancy is made on the CT scan of the chest with one of these features, either a large burden of disease that very often will be unilateral, or occasionally the CT scan may demonstrate an extraluminal extension of the disease or pulmonary metastasis. It is important to remember that these patients will progress despite anticoagulation, and if a patient is started on anticoagulation for suspicion of acute PE and his symptoms worsen despite the anticoagulation, a possibility of malignancy should come on the list of differential diagnosis. Occasionally, a cardiac MR or a PET scan can be helpful to tease out the possibility of malignancy, and these are increasingly frequently performed. A tissue diagnosis can often be difficult to get, and therefore the process to take this patient to the operating room often are based on suspicion rather than a diagnosis made preoperatively. Occasionally, the pulmonary artery can be accessed for biopsy with an IBUS done through the distal trachea, where the mass that could be located in the right main pulmonary artery could be accessed with omnibus, obviously with some risk on hardly performed, but a possibility. And it is also important to remember that the intimal sarcoma generally will frequently extend towards the pulmonary valve. So an involvement on abnormality along the pulmonary valve should also raise concern about the possibility of sarcoma. So this is generally the algorithm that we take to assess these patients. So if we suspect that there is a pulmonary artery sarcoma on the CT scan, we look at the possibility of a complete resection. So generally, we look at whether the disease is unilateral or not. If the disease is unilateral, then these patients can be evaluated for a pneumonectomy, and then the proximal extent of the disease may require a reconstruction of the main pulmonary artery. And intraoperatively, the final diagnosis on evaluation is done with a frozen section to confirm the malignant characteristic of the tumor, and also to determine the completeness of resection with a frozen section, particularly in the section of the pulmonary artery. If malignancy is confirmed and a zero resection is feasible, then patients on the surgery can proceed with a pneumonectomy. If the tumor is not completely resectable, either preoperatively or intraoperatively, then the assessment relates to whether the patients can have a pulmonary endarterectomy, and that will directly depend on the presence of extraluminal extension of the disease. If the disease is purely intraluminal, then these patients can have a pulmonary endarterectomy, which will improve their quality of life, their symptoms. It will not be a curative surgery. The resection will be an R1 resection, but it will again improve their quality of life and is a valuable option for these patients. If the disease extends beyond the wall of the artery, then palliative treatment, generally with chemotherapy, will be the main treatment. These pulmonary artery sarcoma are rare. In our experience at the Toronto Journal, with about 450 cases of pulmonary endarterectomy, we have encountered about 8 patients who required resection for malignancy, generally pulmonary artery sarcoma, and occasionally metastasis, renal cell carcinoma, or osteosarcoma in one patient, in a pediatric patient. The technique of pulmonary endarterectomy that we use for these patients is the same as those used for chronic thrombotic pulmonary hypertension, with a median stenotomy, the use of cardiopulmonary bypass, deep hypothermia with circulatory arrest at 18 to 20 degrees Celsius, in order to be able to visualize the segmental component of the pulmonary arteries. The approach is through a sternotomy, intrapericardial approach, in order to limit the extent into the pleural space, where generally there will be adhesions, and typically the procedure will be bilateral, and that includes as well pulmonary artery sarcoma. In the pulmonary artery sarcoma, the tumor can extend into the wall of the artery more than with chronic thrombotic disease, and therefore the resections occasionally can be more complex. This is a schematic of the technical approach with cardiopulmonary bypass for the aorta, 2 single-stage venous cannula for the SVC and IVC. The pulmonary artery is dissected on both sides. Generally, we will section the arterial ligament, and then the exposure of the right pulmonary artery allows a longitudinal incision, and then the plane is elevated, and the dissection goes along the intima and the media of the pulmonary artery, and then extend into the distality, as I will show you on a short video. So this is a short video of a patient with chronic thrombotic pulmonary hypertension. This is the right pulmonary artery. that is open from behind the aorta all the way to the right upper pulmonary vein. The plane of dissection has been elevated and advanced into the segmental branches. And this is the component under circulatory arrest, which allows us to do the dissection at the level of the segmental and subsegmental branches without any back bleeding from the bronchial circulation. So the plane of dissection is circumferential. We elevate and separate the cast from the wall of the artery at the level of the media, and then we progressively pull the cast into the field of surgery, and we use this blunt dissection with a suction tip in order to gently dissect into the periphery of the artery. And then at the bifurcation, we go more distal in the subsegmental branches until the tail is coming into the field. These are the type of specimen that we can get along the main pulmonary artery or lobar arteries as level 2 for lobar arteries, segmental arteries, and occasionally we can also reach disease that is predominantly located in the distal segmental arteries or subsegmental arteries with excellent optimization of the hemodynamic postoperatively. So on the in patients with pulmonary artery sarcoma, we use the same technique. So if the disease is bilateral, as in the patients that are presented, we will ensure that the disease does not extend outside of the wall of the pulmonary artery and determine the feasibility of the pulmonary endarterectomy to resect the intraliminal component of the disease. In that specific patients, it was difficult to tease out whether that extension was tumor extending through the wall of the artery or if it was a separate component of the tumor that was extraliminal. That component was clearly intraliminal. So we did an MRI in order to tease that out, and the MRI did demonstrate the intraliminal component of the disease, but the extraliminal component of the disease was mostly nodal disease in the orthopulmonary window, which was extraliminal or not connected to the intraliminal component of the disease. We therefore proceeded with the pulmonary endarterectomy and resected the disease. That part of the disease was malignant, and that was associated with some chronic thromboembolic disease on the left side, and then on the right side as well. A mixture of tumor and clot was also found on the right side. The nodal extension of the disease was not touched at the time of the surgery, but reevaluated postoperatively. And you can see in follow-up that the lymph nodes were still present, and therefore we reevaluated the patients with a PET scan, demonstrating that the disease was confined to that orthopulmonary window lymph nodes with no other activity on the PET scan. On that patients therefore underwent adjuvant radiation therapy to that area of the tumor postoperatively at the level of station 5. The final diagnosis of the tumor was a sarcomatoid carcinoma, and the patient is currently alive without recurrence over 6 years from his resection. This is another type of situation that we can face. This is a patient's 53-year-old man who presented with progressive shortness of breath on chest pain, which was diagnosed as an acute PE, but his symptoms continued to progress despite the anticoagulation, and he was reevaluated. And on the follow-up CT scan that you can see here, the clot had progressed towards the main pulmonary artery, and the possibility of malignancy was raised, and the patient referred to us. His disease on the CT scan was localized only on the right side, only intraliminal, with no extension into the main pulmonary artery or into the left lung. Therefore, patients who could potentially be approached for a right pneumonectomy with a complete resection. This is another patient, 45-year-old woman, who also presented with chest pain and shortness of breath, diagnosed with an acute PE, on progression despite anticoagulation. But in contrast to the other patient, the tumor in this specific patient extended towards the main pulmonary artery and along the left side of the pulmonary artery, putting the patient at risk of a major hemodynamic event, and therefore was referred to us for management. This is a third similar clinical presentation, but a tumor that is more advanced into the right lung, and you can see the right tumor extending into the parenchyma of the right lung, associated with an intraluminal component extending into the main pulmonary artery, and activity on the PET scan in the main tumor, as well as the intraluminal extension to the main pulmonary artery here. So these three patients were treated very similarly on the approach with sternotomy, cardiopulmonary bypass, dissection of the right and the left pulmonary artery. The pulmonary artery is then opened in order to get frozen section for diagnosis. If malignancy is confirmed and the extent of the disease allows a complete resection, potentially with resection of the main pulmonary artery and possibly even resection of the main pulmonary artery and the pulmonary valve, then a right pneumonectomy can be performed with a Dacron patch reconstruction for the main pulmonary artery that extend to the left main artery, and reconstruction of the pulmonary valve if necessary. If during that process malignancy is not confirmed, but the disease is truly a chronic thromboembolic disease, then these patients can proceed with a pulmonary endarterectomy. Or if the disease is not completely resectable, then the alternative options is a pulmonary endarterectomy in order to provide hemodynamic improvement and improvement in symptoms as well. This is another patient who presented acutely and also was treated for acute PE and then progressed and then was urgently referred to us about 6 weeks after the initial acute event. She was referred to us to a critical stage and eventually underwent on acute pulmonary endarterectomy. On the CT scan, the disease was localized mostly on the right side at a lobar level, but there was disease extending to the pulmonary valve that initially was not appreciated on the CT scan and retrospectively could be seen. There was a thickening along the valve of the pulmonary valve on some calcification that you can see on the sagittal cut, which is what we found intraoperatively when that patient was brought down to emergently to the operating room. This is the intraoperative finding with the tumor extending into the main pulmonary artery, affecting the pulmonary valve and extending into the RVOT. And then that patient underwent a pulmonary endarterectomy with reconstruction of the pulmonary valve, and the pulmonary artery was left intact otherwise. And this is the follow-up scan. The survival after resection of pulmonary artery sarcoma is leading to a median survival generally of about 18 months. Most series are relatively small. This is the one from Paris with Philippe Dartevel, which is the largest series published with 31 patients. And you can see the clinical presentation from these patients. About half of the patients presented with a clinical presentation suggestive of chronic thromboembolic pulmonary hypertension. 6 patients presented in the acute setting, suggesting an acute PE. 7 patients were referred for a presumed diagnosis of sarcoma based on the tumor infiltration or large mass in the right or the left lung. 2 patients presented with pneumonia, and 1 patient presented with a fibrosing mediastinitis. A preoperative diagnosis was obtained only in 5 patients prior to the surgery, and the median survival was 17 months, which is quite typical. But you can see that there is occasional patients who will have a long-term benefit from the surgery here. This is a literature review that was performed by Dr. Blackman in MD Anderson, and summarized their experience with 8 patients and reviewed 57 patients from the literature, and look at the survival based on different characteristics. And one of the main differences was the ability to perform a complete resection versus an incomplete resection, including thromboendarterectomy, where no patients survive beyond 4 years, with a median survival of about 11 months in that series, while patients who had a complete resection did achieve long-term benefit in some patients. Patients who have a thromboendarterectomy, even though they will recur and have progression of their disease, will still benefit from the surgery in order to alleviate the hemodynamic component of the disease with a risk of impact on the right outflow tract. So in conclusion, resection of tumors extending to the heart is rare. Cardiopulmonary bypass, ECMO, and endovascular aortic stent can provide support to achieve an R0 resection. Pulmonectomy with reconstruction of the main pulmonary artery and occasionally of the pulmonary valve is an option for unilateral sarcoma. Otherwise, pulmonary endarterectomy is an alternative approach for pulmonary artery sarcoma, when complete resection cannot be achieved with benefit on their quality of life despite recurrence of the disease in the midterm. Finally, would like to thank you for your attention, and I will be happy to take some questions. Thank you.
Thank you very much, Mark. That was a very, very interesting talk. You are a world expert in pulmonary endarterectomy. You had a long training in that, and you've come back here to Toronto General and really championed that, and you really are a light in the world with respect to pulmonary endarterectomy, in addition to other things. Your pulmonary endarterectomies are completely different than the pulmonary endarterectomies that are done in the world. Unless you come from France, where you trained, most of them do not look like yours, and you wonder whether or not it's an old study by Shauna Blackman, whether or not some of those pulmonary endarterectomies were incomplete and they had R1, not R1, but R2 resection margin, in other words, gross tumor left behind. If you do a pulmonary endarterectomy and you find in the pathology that you get back that the person did have a sarcoma, any other treatment? Do you use radiation? Because, as you've said, I think the gold standard is still resection and reconstruction of the pulmonary artery, but here you found it coincidentally in an endarterectomy specimen. What would you do differently for those kinds of patients, if anything?
Yeah, these are very good questions, RG. Sometimes we can have, unexpected finding in the OR, and we still proceed the same way. And postoperatively, we will have a discussion with the oncologist to see if further treatment is beneficial. And very often, the option will be chemotherapy, and often they will not have chemotherapy. Probably about half of the patients will do on those, the other half won't. The treatment is not curative, even if you resect the tumor completely, unless it's a very localized disease, like the patient with the sarcomatoid carcinoma, which was very unusual. His tumor was probably more central on so far it seems to be okay, but most of the patients otherwise will recur. On whether probably giving them chemotherapy will prolong their life, but it comes down to a quality of life decision with the patients, although to a large extent. Radiation is often not done because of the risk on the heart. Like, these are tumors that are often close to the heart, and because of the risk of complication or side effects on the heart, this will be less frequent. But like that patient again with the hilum who had radiation was within the range of what we typically would do for lung cancer. But I would say most of the time surgery will be the main treatment.
when you see a recurrence in a pulmonary artery sarcoma after an endarterectomy, is it localized or distant? I've not had very many of these. I've resected the people's outflow tract and the main pulmonary artery down to each hilum. So it's really central disease I'm dealing with. You're dealing with more peripheral disease with the tumor found as well. The recurrence has been distant in the lungs. They die of lung mets. What about what do you find?
They're the same. Like, so if you do another resection, if you can do a complete resection, they will typically come back with distant recurrence. Lung mets will be one of them, or other distant mets will be the type of recurrence. If you do a pulmonary endarterectomy, they will recur within the lumen of the artery. The patient who had the pulmonary valve resected with the endarterectomy had recurrence in the RV, right ventricular outflow tract. So they become, palliative quite quickly once they occur.
Yeah, I think that's a good lesson for those people. Again, people who are tuning in are watching really world experts talk about these sorts of things. You're seeing a world expert here in pulmonary endarterectomy. But one of the takeaways in this particular statement is that the pulmonary valve is involved very frequently if it's in a central portion. And when you resect the pulmonary valve, you can't just resect the pulmonary valve. It's actually an RV, right ventricular outflow tract resection in addition to the pulmonary valve. If you stop right at the pulmonary valve, you're going to have a positive margin and probably early recurrence. Was that patient an early recurrence, Mark?
Yeah, that patient occurred about 12 months, 12, 18 months post-op. She survived, I forget the exact amount of time, but it was, if I recall correctly, like 18, 20 months. So, within the range of what is reported, in the literature. But I've seen patients recur much faster on I think there's still a debate among surgeons who do pulmonary endarterectomy whether pulmonectomy is a better option, or they should be palliative and just have the endarterectomy. Nobody has the right answer. So, but certainly what I've seen occasionally with at least in one or two patients, when you do the endarterectomy, they can recur quite quickly. To me, it seems that if you can do a complete resection in a patient who have limited risk otherwise, and often the lung that you're going to resect is not functional, so you actually don't compromise the hemodynamic by doing a pneumonectomy. And if you can do a complete resection, I think there is still some benefit to proceed with that option primarily, rather than trying to do palliative endarterectomy. So it's still a debate, and I think it depends a lot of the patient's conditions on comorbidities. But it's certainly a palliative procedure leads to potentially rapid recurrence, which is not very satisfactory. If they develop recurrence within 6 months or so.
Thankfully, pulmonary sarcoma is not very common.
Yeah.
This morning we heard about complex tumors that involve the heart, and other than just the one that sneak into the pulmonary vein into the heart, more complicated ones. Dr. Reardon this morning spoke about their Texas two-step approach, and I've been involved with the discussions about him about that. What they do is they go in one day and resect the cardiac portion, so remove that portion of the cardiac, the tumor in the lung that affects the cardiac or the mediastinal tumor, and leave that alone, let the patient recover from that operation, and then the next day go back and do a pneumonectomy. And they found better results doing that than if they did it all at once. Would you comment on an approach, a two-stage approach to that, a 2-day approach, 2 or 3 days later or whatever, leaving the lung not attached to the heart, and then going back a few days later and removing the specimen?
Yeah, I think that's a great point. On the doing a two-stage approach is has a lot of benefit. I mean, the big problem when you do a pneumonectomy on cardiopulmonary bypass is the bleeding issues. And if you can do the component on cardiopulmonary bypass, normalize the coagulation, let the patient recover, and then go back, even through a better approach, by doing a thoracotomy, you'll have better exposure of the posterior mediastinum or middle component or hilum, middle component of the mediastinum or the hilum is involved. Then you have two benefits, I think, doing it two stage. On the thoracic side, we do a fair number of spinal resection in 2 stages. So the posterior approach is done by the spine surgeon at the Toronto Western, and then we do the second step with the long resection at TGH. On that has worked very well. So rather than doing a 12, 18 hours operation, you break it down into two reasonable days of surgery on patients do recover faster. So having a stage operation is actually a very good option. I agree here. On plus the coagulation component that certainly will be beneficial by.
How long do you wait when you do the spinal surgery and your operation?
Usually we wait 6-7 days.
6 or 7 days.
Yeah. So the lung is still perfused. So there's like if you remove the cardiac component, you may have taken some of the pulmonary vein, or I guess maybe the pulmonary artery, but certainly the pulmonary vein, I suspect, will be removed with the cardiac component. So the lung may not be perfused, so it may not work to leave them for as long, but certainly from a spine perspective, 6-7 days has not been a problem.
Yeah, I've been involved with some combined pneumonectomy, cardiac cases, and they're high-risk patients, to say the least.
Yeah. No, I think certainly a pneumonectomy on cardiopulmonary bypass is potentially a problem. The ECMO has been quite beneficial. Obviously, you have to be within a closed system, but if you can use ECMO rather than bypass, I think that's becoming a very advantageous option. Like for carinal resection, rather than doing cross-field ventilation, if you put them on VA ECMO, you can do surgery without much problem from a ventilatory perspective. On the amount of heparin you give is low enough that you have very minimal bleeding problems. So it's certainly increasingly becoming an advantage as well if it is an option based on the location of the tumor.
Yeah. Again, Dr. Perrot and the group here at Toronto General Hospital have a gigantic experience in VA ECMO. And it's one of these things, don't try this at home. You have to be, just like Dr. McGilvery said and other people said, and Dr. Rogala said in this morning, is that if you're going to try some of these things, you better make sure you know what you're doing, go get trained or ask for help. Definitely ask for help. The group here is an amazing and an outstanding group of thoracic surgeons, and they have a huge experience in the things that Dr. Perrot spoke about. It's a center of excellence here for all of Canada.
Yeah. No, these complex cases, you benefit a lot from discussion on everybody comes with their own input, and I think building a team effort as to how best to approach these tumors is very beneficial. So I think the teamwork is a big component of these success for this type of tumor.
Yeah, we take it for granted here in this hospital that we almost don't even talk about it. But I think around the world, it's something that people can strive to make teams like we have here in this hospital.
Mm-hmm.